Hello, YouTube world. It's Miss Patty with For Your CNA, and we are live just like we are every Thursday at 3 p.m. Eastern, although I am a little bit late today. I'm so sorry, guys, got held up. I am here to answer all of your questions on CNA training, testing, or workplace issues, or just have a general conversation about whatever's on your mind. So leave me a message in the chat when you join. Give me a thumbs up. Let me know that you're here when you come in. And as always, as we get started, while I'm waiting for you guys to come in, I usually give some sort of a mini lesson on something. And this is something that actually came up in my class yesterday. I graduated a group out yesterday, and this is a topic that we got into about DNRs. For those of you that don't know what a DNR is, it's a do not resuscitate. And there's a lot of confusion around DNRs. I mean, a lot of confusion. Even within the medical community, there's confusion about it. So I want to take just a couple minutes to clear some things up, maybe some misconceptions about DNRs, explain what they are, what they mean, what our responsibility is as CNAs regarding DNRs, and do you get in trouble if you don't follow them? What are the consequences? So I want to kind of go over this really quick. Hi, Ida. Hi, Hamza. Thanks for joining us today. So DNR is a legal form. So do not resuscitate. It's a yellow legal form. At least in Florida, it's yellow. Other states have a little bit different system, but it's a legal form. Now, I've heard stories and I've seen things on Facebook, people that have like DNR tattooed on their chest, right? And this just kind of makes me laugh because that means absolutely nothing. You know, it doesn't mean anything. It could stand for do not eat refried beans. I mean, it doesn't really mean anything, those initials. The form is what means something. Okay. Now, this form, this legal form, you can't even fill out yourself. So let's say you don't want any resuscitation efforts. If something were to happen to you, you are not allowed to fill out a DNR. The only person that can complete a DNR legal form is the doctor. And then the patient or the patient's representative has to sign it as well. But the only person that can initiate it is the doctor. So let's get that clear right up front. This is a legal form that must be initiated by a doctor and then signed by the patient or the patient representative. Now, so why would we use a DNR? Well, we need to understand, in order to understand what a DNR is, we need to understand what CPR is and what life-saving measures are. So CPR, when you take a CPR class and you learn to, push down on the chest about 100 times a minute, all you're doing there is circulating blood. That doesn't help it doesn't bring anybody back. All it does is circulate blood and buy us time. That's it. That's all CPR does, is buy us time. So what do we need time for? Well, what we need are medications and treatments that can fix whatever's wrong with the patient so that we can stop this dying process. So when you're pushing on the chest or putting air into the lungs, all you're doing is buying time. Okay. So what we need to do is fix the problem that caused the death. So is the problem a heart attack where the heart just suddenly stopped, or is in a dangerous arrhythmia? Is the problem because the patient OD'd? Is the problem because the patient doesn't have enough blood in their system? They have internal bleeding or external bleeding. What is the problem that brought us here? We have to fix that problem. So for CPR, all you're doing is buying time. That's it, for somebody else to figure out what the problem is and provide a treatment for that to fix the problem, right? So CPR buys time for us to fix the problem that caused the death. Got it? So now, where does a DNR fit into this? Well, when somebody has a life-ending disease, what we call a terminal illness. So this is somebody that has an illness that is expected to end in the patient's death. We can't fix it. Okay. It's something that's beyond our ability to fix. So this would be like end stage Alzheimer's. We can't fix that. End stage cancer. We've tried everything we have to throw at it, but it's not fixable. The surgery didn't work. The chemo didn't work. The radiation didn't work. Nothing has worked. It's not fixable, right? So this patient is expected to die at some point in the near future. This is an expected event. The patient's aware of it. The family's aware of it. The doctor's aware of it. Nothing we can do about it, right? So that we know it's coming. We know it. So the doctor has a conversation with the patient and says, okay, we've done everything that we can do. We can't fix the problem. So when it ultimately takes your life, what do you want done? Do you want us to do CPR? Remember, all CPR does is circulate blood that buys us time to fix the problem. Well, we already know we can't fix the problem. We've tried fixing this problem for months and months, and we can't fix this. This is unfixable. So do you still want CPR? Which really doesn't make any sense because CPR buys time to fix a problem that we can't fix. So CPR at that point, right, at the end of a terminal illness just doesn't make sense. Why would you why would you have this very traumatic experience to buy time that's not going to fix anything at the end of the day? So some patients are like, yes, I want CPR. I want every measure possible. I want every spare second of this life that I can get. Okay. So in that case, when the patient passes naturally, we'll do CPR, we'll give medications, we'll try to get the heart started again. But remember, what killed the patient is still on board. So it's going to kill them again. Okay. So they're going to die again, probably pretty soon, because it's not a magic reset button. You don't get to respawn on another area of a map somewhere with full health. It doesn't work like that. So a lot of people, when they understand this, okay, I have end stage terminal cancer. I am not going to make it. The medical community has done everything they have for me. It doesn't make sense to try to do CPR after I pass. So I don't want any of those measures. Just let me pass peacefully. Keep me comfortable. I want to be comfortable. I don't want to feel it, but let me pass peacefully and then leave my body alone once that happens. There's no need to buy me more time when the disease has already run its course. So that is when a DNR is put in place. So the doctor and the patient, or the doctor and their representative, have this conversation. They come to this agreement. A legal form is filled out. We now have a form that says when the patient dies of expected causes. So that's important. Make sure you understand that expected death. And I keep stressing that because it's going to become important in a minute. When this disease has the expected outcome, leave me alone. Okay, that's what a DNR means. Okay. So let's say that we have a patient who has cancer, and they have a DNR in place, right? And they're in Walmart buying pickles in the pickle aisle, and all of a sudden they have a heart attack and they fall to the floor. And you happen to also be buying pickles and you see this, and you immediately begin CPR because you're a healthcare professional and that's what we do. Patient falls unexpectedly, has a traumatic, unexpected event. We do CPR. That's what we're trained to do. And the patient's family says, oh, he's got a DNR, get off of him. He's got a DNR. Well, guys, remember I said DNRs only go into effect when you die of the expected event, expected, right? The DNR is not really having an effect in the pickle aisle at Walmart. That's not that heart attack is not an expected event. So you keep doing CPR until somebody with medical authority comes along and tells you to stop. It kind of is that simple. Now, in a healthcare facility, that patient has broken their hip and they have cancer, they have a broken hip. That DNR, people will say, well, I don't know why they're doing surgery on that patient. They have a DNR. That DNR does not mean anything at this point. Remember that a DNR only goes into effect when the patient dies of expected illness, terminal. Okay, it's expected. We know it's coming. A broken hip has no impact on that. So if you've got a patient with a broken hip, then just because they have a DNR doesn't mean anything. That the DNR only comes into effect when they've died. Your patient is still alive. That DNR has no bearing at all. None whatsoever. So we need to kind of understand that DNRs are legal forms written by the doctor to tell us as the healthcare team what to do when the patient dies of an expected event. Anything else is business as usual. Okay? Business as usual. Start CPR, call for help, let somebody know what's going on, circulate the blood until somebody else can come along to fix the problem. We're buying time. That's all we're doing with CPR, guys, is buying time. That's it. So you circulate the blood and buy time until somebody else can get there to maybe correct the problem. Now, we may not be able to correct the problem. Possible. CPR is not 100% effective 100% of the time, but you do what you need to do. Now, if a nurse comes along and says, stop CPR, remember that we follow the care plan, right? That's all we do as CNAs is follow the care plan. So if the patient has a DNR and has an expected death event, CPR is not necessary. It's actually not required. It's in the care plan that we're not going to resuscitate. So we're going to follow that care plan because the care plan says DNR. But if the care plan does not indicate that they are a DNR, we're going to do CPR. What if you are a sub at a facility, right? So travel CNA is becoming a huge thing. Now, this is one of the problems with travel CNA, though. You don't know your patients at all. You're brand new to this facility. You can't, you don't know the difference between Charlie or Harry or Mildred over there. You don't know their names. You don't know who they are. You really don't know the care plans well at all. So somebody has a death, you jump in there, you start doing CPR. Are you going to get in trouble? Well, what you're going to get in trouble for is not following the care plan. Okay, that's really what the problem is here. You didn't follow the care plan. So this is why it's really important when you take on a new assignment and you don't know the patients very well, that you take the time to make sure that you're getting a good report and know who's a DNR and who's not, because it doesn't make any sense to put the patient through that kind of trauma and the family through that kind of trauma when it's not going to fix anything at the end of the day. So remember that we are all about the care plan, right? We follow that care plan. Well, DNRs are part of the care plan. And that's really where we need to focus is the effect of that on the patient and on the care, not following the care plan. So when it comes to DNRs, the three things that you need to remember is, number one, they're a legal form that must be started by the doctor. Okay. Has to be initiated by the doctor. The second thing is it never goes into effect until the patient is dead of what we expect them to die of. Third thing is it does not impact treatment at all. Remember, it only goes into effect when they're dead. Treatment is what happens when they're alive. So it has to be initiated by the doctor. It is in response to a terminal condition, an expected death, and it doesn't go into effect until they're dead. Okay. So those are the things that I really need you to understand about DNRs. And I also want you to understand that CPR is not what a lot of people think it is. CPR circulates blood to buy us time so that we can put medications in or do treatments like defib or something like that to correct the problem that caused the death in the first place. If we can't correct those problems, there's no real sense in buying any more time. Hope that helps a little bit. Okay, so let's see who's here. Hi, Alina. Hi, Laurent. Hello, Gloria. Thanks for coming today. Hi, Jazz. Hi, Yvette. Thanks for showing up today. Ramses, hello. Jennifer, hey. Jennifer has a question. Okay, do people in assisted living have to be able to use the toilet? Are they accepted if they have to wear briefs? Yeah. Okay, Jennifer, let's go way back a couple of months ago. We had a conversation about the difference between personal care and nursing care. And it's really important that we get this, right? So anything you do for yourself every day is personal care. So this would be like bathing, dressing, grooming, toileting, feeding, mobility. Those are things you do for yourself every day, right? So if you can't brush your teeth, somebody can help you brush your teeth. If you can't clean yourself after the bathroom, somebody else can help you clean yourself after the bathroom. If you can't feed yourself, somebody else can help you feed yourself. These are personal care tasks. They are not nursing. Not nursing. Let me make that. I'm going to make a really big neon billboard, right? Personal care is not nursing. So assisted living can do any personal care, any and all personal care. So assisted living, it really is appropriate to have somebody who is totally incontinent and wears briefs. There's no problem with that because toileting or cleaning up after toileting or not being able to toilet at all is not nursing. Okay. Nursing is vital signs, observation and reporting, helping with oxygen, taking care of catheters, helping patients put on their O2 cannula. Those types of things are nursing. You need additional training for that. Personal care is not nursing. So yeah, absolutely. In assisted living, they can absolutely be eligible for assisted living if they're totally incontinent, totally, or if they just accidentally incontinent here and there and need to wear briefs. It doesn't matter. They are still appropriate for assisted living because personal care is what we do in assisted living, and personal care is not nursing care. I hope that helps. Hi, Makayan. Kanisha says, I had hand washing, measure, record pulse, foot care, and indirect care, and I passed those except change of position. And I didn't pass the written test either. Oh, Kanisha, I'm so sorry to hear that. So change of position. I'm not sure what you did wrong, but there's a couple things that I probably can guess at. Okay. So number one, and this is the most common reason people fail change of position, is that after you turned the patient, they were not in the center of the bed. When you turn a patient over, you have to make sure that after the turn, they're in the center of the bed. Well, that's a problem because if they're on their back to start with, they're going to be on their back in the center of the bed. So if you roll them, they're going to be near the edge. So you have to scoot them towards you first, then roll them on their side. So after the roll, they're in the center of the bed. So that could be one thing that potentially failed you. Another is that you didn't put the pillows in the right places. So we have to put a pillow behind their back to keep them from rolling onto their back. Because guys, the way the body is shaped, most of your weight when you're on your side is distributed along your back. So you're naturally going to be rolling back onto your back. We need a pillow there to keep that from happening. But you also need one between the legs, specifically between the ankles and the knees. Those bony areas, we don't like those to touch. And then you want one under that upper arm to keep it in a nice neutral position so we don't have muscle spasms or headaches or things like that. And then adjust the one under the head. Now, one of the other things that is less obvious that can fail you on change position is that the call light must be placed directly in their hand, and that call light cord cannot go over their head or neck, right? Because that's a choking hazard. So you need to reposition that call light cord around the mattress so that you can put the call light directly in their hand. So I hope that helps you. Those are some things that could potentially fail you on changing position. Hey, Blue. Thanks. Welcome back. Carrie Ann says, good evening. How can I get a temporary CNA license? Oh, Carrie Ann, this is a very good question. There is a website that you can go to do, I think it's 8-hour or 16-hour training to get a temporary nurse aid certification, but this is big. This is huge. Pay attention to this. That temporary nurse aid, the last day to get it is on June 5th. Then they're shutting it down. And those that have the temporary nurse aid must have their state certification by October 6th. October. I think it's October. It's either September or October. I can't remember, but it's 4 months. So if you get your temporary, you can just Google temporary CNA certification. There's a website. It's AHCA, AHCA, that you can go to get that temporary certification. But make sure that you understand that facilities can only work you for a few months with that temporary. You must transition that by taking the state exam into an actual certification, because that program is ending. Okay. So that's about the temporary. My Pierre, hi. Sharon says, good day, everyone. I thought having a DNR helps determine the kind of treatment a patient gets, and it didn't matter whether you had a terminal illness. Oh, yes, Sharon. I know there's a lot of misconception about DNRs. DNR has nothing to do with treatment. Nothing. Not a single thing to do with treatment, ever. It does not define treatment, and you must have a terminal illness to get one. Okay. And remember, it has to be initiated by the doctor. Snatch Master says not all heroes wear capes. Well, that's very true. Most of us wear scrubs. Blue says, Miss Patty, I also talk about DNR in my home health aid classes. I'm sad this is not a retired topic to discuss with CNA, HHA, or HCA students. I agree, Blue. I think this is something that's very important. And I think there's a lot of misinformation out there about DNRs. And I think that it's something that we really need to make sure that our healthcare workers are well educated on. Let's see here. Jennifer says, so caregivers are trained to change briefs and on Pericare. Yeah, absolutely. Not all, Jennifer, not all programs are going to train you on changing briefs because it's, it's similar to putting on, underwear or, diapers on a child. The body's just a little bit bigger. So it's not always trained in a training program. So something that a lot of students don't understand is that not everything that you're going to have to do on a daily basis is going to be covered in your CNA training program. That's just going to provide a foundation. Some other things that you're going to have to learn to do, you'll actually learn to do on the job. And some of it is patient specific, right? So in my career, I've helped a lot of people with adult briefs, and some of them wanted to be standing up because they had the pull-up kind. Others needed to be laying down. Some patients could roll themselves. Others could lift their hips. Some couldn't do anything for themselves. So every patient is going to have to be addressed a little bit differently. And some of that you're going to learn during your orientation period when you go to work. So not all of the education that you're going to need is going to happen in the classroom. Some of it is going to happen on the job, specific to each individual patient. Denise says, good afternoon. Blue says, Jennifer, I teach home health aid classes. HCA students are tested on Pericare and brief changing. at least in Washington State. Hi, Ciliana. Ciliana passed the test last week. Congratulations. Great job. Jennifer says, so a person on oxygen can't be in assisted living, being that is a nursing skill, even those with an oxygen tank. Okay. So let me see how I can explain this. Patients in a house, in a home, right? So let's say that I have congestive heart failure or I have lung cancer, and the doctors have made the decision that I need to be on oxygen full time. So they give me this little thing that I plug into the wall. It produces oxygen, and I put these little prongs in my nose called nasal cannula, and that delivers oxygen to my body. But I still live at home, right? I don't need a nurse to, when they give me that machine, they train me on how to use it, how to turn it on, how to put the cannula on. I get all the training I need, but I'm managing it myself. So people can do that in a home setting. Just because you're on oxygen doesn't mean you need to be in a hospital or a nursing home. People manage their own oxygen very well. Well, remember that assisted living is a home-like setting. So if you've got a patient that can manage their own oxygen, they can live in an assisted living facility. It's okay, but they have to be able to manage their own oxygen. If you've got an advanced dementia patient who's not able to manage their own oxygen, advanced dementia, but they've got other health problems and they're on oxygen, if they can't manage that themselves, then they would need some sort of higher level assessment, right? Somebody to keep an eye on them, to look for color changes, to look for shortness of breath, to check their vital signs. That would elevate it into a nursing task. So just being on oxygen doesn't necessarily mean they can't be in assisted living, as long as they can manage that oxygen themselves. Because, you see people out at Walmart on oxygen, or at Winn-Dixie, or eating dinner at Chili's on oxygen, because it goes with them. They have portable oxygen machines now, which is awesome, by the way. But just because they're on oxygen doesn't mean they can't be in assisted living. It's when they're unable to monitor their own oxygen levels and health status that we need another person to be able to do that, that's trained. Now, when it comes to assisted living facilities, oh, thank you, Denise. The temp license expires October 6th. Thank you. I wasn't sure which one it was. But when we're talking about assisted living facilities, it's important to understand that there's different levels of assisted living. So you've got base assisted living, meaning no nursing tasks. It's all personal care. No nurse lives there. No nurse visits there. It's all personal care. Then you've got something called a limited nursing license that some ALFs can get. And the limited nursing means we do have a nurse here. She's not here. She doesn't live here all the time. She's not here 24/7, but she's available by phone if there's a problem. So we can do some nursing tasks here. And that nurse is going to train the caregivers on what needs to be done. And then there's another step up as well, that allows them to do even more advanced nursing tasks, which means they have a nurse on staff 24 hours a day and rotating shifts and things like that. So there's different levels, and it depends on the assisted living facility, what licensure they have. And it's up to them to know which patients are appropriate for assisted living and which would need a higher level of care and be transferred out. But for the most part, we try to keep patients all in the same place as long as possible, because it's very stressful on people so think of it this way, guys. When you don't feel good, you want to be home, right? Home is your safe place. It's your couch. You can curl up. It's your TV. You can watch. You feel comfortable in your little nest. That's where you want to be. And it's very disruptive to your life to have to leave that nest and go to a hospital or go somewhere for treatment. You really want to stay in your little nest. So assisted living is where they live, right? That's their final place. It's where they live. So we try to keep them there as long as possible. And that's where these additional ALF licenses come in, because if we have a nurse on staff and the patient has conditions that are within our ability to manage there, we can keep them there longer, keep them comfortable in their environment longer, rather than have to transfer them out to a nursing home, which is unfamiliar, different staff, different rules, different everything. And that change can affect the elderly very significantly. So we try whenever possible to keep the patient in their trusted environment as long as possible. Hope that helps. Um, so let's see. I lost where we are. Hold on. Let's see here. Madeline, hi. Kanisha, I forgot to put the pillows under the neck and between the legs and under the arms. Oh, that makes sense, Kanisha. Yeah, they really want to see those pillows in place. So you'll smash it next time. You'll do a great job. See here. Peace says, hi, Patty. Great to see you. Thanks for your videos. I smashed my exam. Oh, great job, Peace. Congratulations. Blue says, I'll let Patty answer for Florida, but in my state, from my experience, yes, a person can be on oxygen in assisted living. Yeah, that is true. However, it depends on how much skilled nursing they need and determines if they need to be in skilled nursing. Yes. Monique says, shalom. Shalom, Monique. Jeff D says, hi, everyone. Glad to be here to increase my knowledge. Well, thank you for joining us, Jeff D. Letitia, hey. Kanisha says, how long do I have to wait to apply again to take my clinical exam over? Will I only have to go take the change? Okay. Good question, Kanisha. So there's two parts to your question. The first is, how long do you have to wait? 30 days. It's 30 days between testing attempts, not 30 days between registrations. So you can go ahead and register now to take the test again. You're going to have to take both parts because you failed both parts. So register now. They'll make sure that the date is at least 30 days from your last attempt. On the application, it's going to ask you, have you taken the CNA state exam before? You're going to check yes. And it's going to ask you what date. So make sure you put the date there. That lets them know your next attempt has to be after that date. Okay. Now, as far as the skills you're going to get a different skill set. You don't go back and just demonstrate the one skill you failed. You got to do the whole test over again, and it's going to be a different skill set. Now, there may be a skill that you did on the first time that shows up again at the second time, but for the most part, it's usually 3 different skills. You can, here it is. Right here, see that the yellow testing care plan sets? Those are actually the testing care plan sets. There's 11 of them. They're already pre-selected, set up and set. You're going to get one of those 11. You got one of those 11 last time. You'll get one of those 11 next time, but they're already pre-selected. Okay. And you will have to take that written test again as well. But you'll be fine. Go watch my videos. Watch the animated video, the animated lessons, and the skills videos. Okay. Let's see here. Blue says, one of my coworkers is an ARNP. She will literally murder you if you refer to briefs as a diaper. Absolutely. These are not children. Don't demean them. Do not demean an adult by referring to anything as a diaper or a bib, or they're not children. You don't treat them like oh man, they're one of the assisted living facilities in my community had this problem, I don't know, 5-6 years ago. Oh, it broke my heart. So in an assisted living facility in a dementia unit, they noticed that the patients were losing weight, and they were trying to figure out why. Well, it turns out that 2 of the resident aides there on the day shift were not giving patients food unless they said please, and taking it away from them unless they said thank you. And these are dementia patients. And they kept saying, well, we're trying to train them. We're trying to teach them manners. That is not your job. You do not try to teach an adult manners. That is so far out of your scope of practice. And yes, they were fired, and God help them if I find out who they are and I ever get a hold of them. That's horrible. You do not treat adults like that. That should, want to pull their hair out. So I'm with your ARNP. Do not call adult briefs diapers. These are not children. These are adults, and they deserve to be treated with respect and dignity. Old age is not a crime. They are not in prison. They just need help. They just need help. So we need to do it with dignity and respect. So no, don't call them diapers. Absolutely. Can you tell that's one of my hot button issues? So Makayan says, can your next topic be on hospice, the care one receive once they are deemed a hospice candidate? My name is Mashane. Oh, I'm sorry, Mashane. Mashine? Mashine? Not sure if it's Mashine, I think it is. Thank you for helping me pronunciation. I like to get things right. So Mashine. Yes, I will. So I'm going to write that down. So Mashine, hold on. You, you picked next week's topic, hospice. Hospice will be next week. Jennifer says, okay, so they can be on oxygen as long as they can manage themselves. Yes. Caregivers aren't allowed to manage it. Again, it's going to depend on the licensure of that ALF. Madrid says, hi, Patty. If you're working for a nursing home and the client wants to take you for private, do you think I can take that case or not? Oh, there's a really good ethical problem. So most places, when a patient gets admitted, they have a form that they have to sign that says that they cannot hire any of the employees there for personal care outside of the facility for something like, a certain amount of time after they're discharged. So I would check with your facility because they may be in breach of that. So that comes up quite often. And so the problem is, right, if that happens all the time, because patients don't know where to go to get good quality help. So when they're in a nursing home, they find somebody they like. Of course, they're going to want to take them home with them, right? Because now I found a good quality helper. It's better than putting an ad in the paper. But if that happens over and over and over again, who's left in the nursing home to take care of the patients that are there? So it becomes a real employability issue. So I would honestly refer you right back over to your facility for that, because you want to make sure that you're not in violation of any of the policies. Monique says, I'm doing my LPN now. Is some of your videos helpful? Yes, absolutely. Remember that LPNs also have to do all of the personal care tasks, but understanding a little bit about everything that I talk about in my animated lessons and in my skills videos, things like infection control, that's universal. It doesn't matter what level you're at. Communication, that's universal. Doesn't matter what level. If the patient's uncovered or undressed, we need a privacy blanket. That's universal. If we're going to move a patient, they need to have shoes on. That's universal. So all of these principles are universal, no matter what level of care you're providing. But a lot of the things that I cover, patient rights, the importance of the care plan, how different facilities work, all of those will help you as well. Unfortunately, I don't. CNA takes all of my time. I've had a lot of requests for help with LPN, but I'm going to kind of stay in my lane. CNA is really where my heart is, because if I can help people start out with a really good foundation, no matter where you go to build on that foundation, those principles are going to guide you along the way. Ida says, maybe a crazy question for the exam. Can you wear a watch? And can it have military time on it? That's actually a really good question, Ida. Now, it used to be, yes, you could wear a watch. Now, because smartwatches can be programmed to look like regular watches, a lot of places are not allowing watches during the test. So in the test, you're actually going to have a clock on the wall right above the bed, and then another one right above the sink. So you have the ability, you'll already have clocks in place. You'll have the ability to tell time very easily without the use of a watch. And that's what the evaluators are using to time you anyway. So you might as well use the same timekeeping device that they are when they're testing you. But most places are not allowing watches now because they can actually be a smartwatch. And yeah, believe it or not, smartwatches can be used to cheat. Isn't that horrible? Fred says, how do I register? For what? Fred, what are you trying to register for? Are you trying to register for my email list or the course or the state test, or I don't know. Help me out here. Mashine says yes. Elaine says if there's a delegate nurse in assisted living facility, the CNA would be taught to handle same. Yeah, yes, you can be delegated additional tasks. And that's something that I am going to cover very, very shortly in the next couple of weeks is delegation. Because there's several things you need to know about delegation. But the biggest one I'm going to leave you with today is that you cannot do a task as a CNA unless you've been trained to do it. So you can't just pull up a quick YouTube video and teach yourself how to take out a catheter because a nurse asked you to. You have to be trained. Now, training doesn't have to happen in a classroom. It doesn't have to happen in a CNA class. Training can be at the bedside. As a nurse, I can train you to do whatever it is I need you to do, but there's some rules I have to follow when I'm providing that training, and that's what I'm going to go over with you in a couple weeks. But the big thing to take away regarding this right now is that if you don't know how to do it, your answer is no. But be open to learning new things. If the nurse says, well, can I show you? Your answer should be yes, because we're all on the same team. We're trying to help the patient. And the more you know to help that patient, the better off the patient's going to be. Elba says, hello, I'm new here. Got my state exam coming up in a few weeks. Oh, how exciting. We're going to push out good vibes to you. Jennifer says, here you can't wear an Apple Watch, just a regular second hand. And Monique says, thank you. Gums says, hi, Patty. My first time watching. I was told I can't raise the bed anymore during the exam. Please explain. All right. So this will be my last question for today because we're running low on time. So Gums, I don't know why somebody told you can't raise the bed, because as far as I'm aware, they are still allowing you to raise the bed for any skill. So any skill that you want to raise the bed up to a comfortable working height. From my understanding, I haven't heard any different. I haven't heard that they're not allowing that anymore. But the big thing is that you have to lower that bed to the lowest possible point before you end the skill. Now, what I tell my students in my classroom is that you really don't need to raise the bed for any skill. I mean, you're only doing 3 skills for the test, right? The test is like 30 minutes long. So bend, right? Because if you raise that bed up to make it comfortable for you, and at the end of the skill, you forget to put it back down, it's an automatic fail. So I tell my students, you can raise the bed if you want to, but why take that chance on the test? Because at the end of the skill, you're just going to be so happy you're done, right? You're like, whoo, man, just squeak that one out. Let me do my closing. Thank you very much, Miss Jones. Here's your call. Light, do you need anything else? Magazine, are you comfortable? Environment's clean. Open the curtain. Go wash my hands. I'm done. Yay, right? You're just like on autopilot then. And unfortunately, because you go on autopilot, you forget to lower the bed. And that will automatically fail you. So because of that, my advice to my students, my classroom students is, unless you really, 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 really have to, like you've got a really bad back, my suggestion, don't raise the bed up. Just do it with the bed at the height it is, get through the test. But remember, when you're out there in a clinical setting, lowering that bed is a super, super important step because the patient expects the floor to be right where they left it. And if it's not, when they put their feet out of the bed, they're not going to look to see if it's there. They're not going to feel to see if it's there. They're just going to swing their legs out, expect it to be there, and they're going to fall. So it is a very important step. I hope that helps. Fred, state test, go to my website, foryourcna.com. This big logo back here behind me, foryourcna.com. Click on testing at the top, and I've got test registration instructions there that'll walk you through every step of it. Okay. Blue says, Miss Patty, I love the card game. Oh, so awesome. I pleaded my case and work is going to let me order a few sets for my coworker and I to use in our HCA classes. Awesome, Blue. Thank you so much. That is super awesome. When you're ordering, Blue, make sure you remember to use the code YT Crew. So for YouTube, right? You guys are my YT Crew. So use the code YT Crew and it'll save you $10 off your order. Okay. Kendall, is the CNA test hard? Unfortunately, Kendall, I don't really have time to get into that because we are out of time. I'm actually a little bit late and I've got to congratulate everybody. But it really depends on who you ask and how well prepared you are. If you're asking me, is the test hard? Nope, not hard at all. But if you're asking somebody else that just failed it, they're going to say, yeah, it's hard. So it really depends. You really just need to be well prepared. And the good news is my channel, foryourcna.com, has all the free videos you need to get prepared for the test. So at the end, when I'm done with you and you're asking, is the state test hard? You can honestly say, no, it's not, because we're going to get you well prepared. And guys, I don't know if you guys know this, but I have a whole online course that goes way beyond my videos. Like what you guys see is the free stuff, right? If I'm giving all this away for free, just imagine what I've got in that course that makes it way easier, right? So I'm not giving my best stuff away for free, and the best stuff, the free stuff is really, really, really good. But I got stuff that's even better on the course. So if you haven't had a chance yet, go check it out. Go to my website, foryourcna.com, click on online CNA test prep course, and go through some of the free lessons. I got like 11 lessons in there unlocked. So go through some of the free lessons. Oh, thank you, Jazz. It's super sweet. I love all you guys too. You guys make my Thursday. All right, here we go. This is the good part of the day today. I get to congratulate all these wonderful people that passed the CNA state exam. So if you guys have passed the CNA state exam recently, make sure you just drop by, let us know, leave us a comment on one of my videos so I can congratulate you on our next live session. So Monique Jordan, congratulations. Naja Sanders, congratulations. We're super proud to welcome you. Ms. Renee passed the CNA state exam, so welcome to healthcare. Dylan Lorenzano, great job. Melissa Calla passed the CNA state exam, so we're super happy. Cherished, I love that name, Cherished passed the CNA state exam. And Nadesha Clayton also dropped by to let us know that she was successful and passed the state exam. So make sure you guys let us know how you're doing so we can congratulate you. Those of you that are getting ready to test, we're going to send you tons of good vibes, including Claudette Thomas and Nam with a Cam. They're going to be testing soon. So we send you guys all kinds of good vibes. You're going to do fantastic. Head over to my website, look at my free videos. Remember, they're free. But check out that course too, because it might be helpful for you. Elvis says it's a great program. I recommend it. Oh, thank you. And a Kendall says you're a great teacher. Oh, thank you. You guys make me. I'm only a great teacher because I have great people to preach to. You guys are awesome. So sorry, guys, I got to run. Got another meeting to go to, but I will see you next week. Same time, same place. Thursdays at 3 on our YouTube channel. Hope to see you here. Until next time, guys, happy caregiving.